Are we ready to kick off, Darren?
Yes, Councillor Alden, we're ready now. It's streaming live now, so we're ready to go.
Okay, right. Good afternoon, everybody. Welcome to the Health and Wellbeing Board held on the 26th of November. Thank you all very much for your virtual attendance. I'd just like to remind everyone that this meeting is being streamed and uploaded to YouTube now for the thousands upon thousands of the viewing public who are currently tuning in. Can I just remind everyone to please mute your microphones while you're not talking and use the raise your hand functions if you want to indicate to speak. We've had apologies from Councillor Gledhill, from Michelle Stapleton, Andrew Pike, Andy Millard and Julie Rogers. Does anyone have any comments on the minutes from the meeting of the 31st of July? I'm not seeing any hands going up, so I'm going to assume that agenda item 3, urgent items. I've not agreed to the consideration of any urgent items. Item 4, declarations of interest. Does anyone want to declare that they are interesting? I'm not seeing any hands, so we will move on. Item number 5, the active places strategy. I'll introduce Lee Nicholson, who is our newly minted permanent assistant director for place, to introduce the item, please.
Thank you, Chair. Good afternoon, everyone. So, as part of the preparation of the new local plan, we've commissioned an active place strategy, or APS. This is a suite of studies that will act as an evidence base to help inform future decision making, ensure our communities have access to high-quality sports facilities, and so they can move safely around the borough. The APS consists of 4 strands comprising an open space and play areas study, an indoor and built sports facility strategy, playing pitch and outdoor sports strategy, and an active travel strategy. So each strand includes a separate assessment of current provision and a report setting out strategic recommendations and actions for how each can be improved, increased, and delivered over that plan period. Having an APS in place will help the council deliver on its broader health and wellbeing objectives, deliver on its sports and recreation facilities objectives over the plan period, and also strongly position the council in bidding for funding to support these objectives, as well as negotiating for funding through future development proposals. Chair, with your agreement, I'd like to hand over to David McHenry from KKP to present in more detail. Thank you.
Yeah, please do.
Yeah, thank you. I'll share my presentation, if that's okay. Can everyone see that as a presentation?
I can, yeah.
Yeah, I'm assuming that's okay. Right, thank you very much, Mr. Chair. David McHenry, Managing Director at KKP. We've worked with the council delivering the active places strategy so that we can really get to focus on the key requirements across Thurrock. So the format of the presentation, we're going to run through the purpose and approach, then we're going to go into the 4 key areas of the strategy, look at some examples, the opportunities, then responsibility for delivery, and then finish off with any questions. The purpose of the strategy is it's really to set the context for providing, or the purpose of this presentation is really to set the context and providing an overview of the work, provide an opportunity and to discuss the links to the health and wellbeing plan, Sport England's national strategy, as well as the active place strategy in terms of how those link across one another, and to provide an opportunity to discuss how investment can be achieved across that period. Obviously, there's a core linkages through to the health and wellbeing strategy in terms of creating places that make it easy to exercise and be active, that's in terms of one aspect of it. The other aspect is ensuring really that those key areas are linked. So as identified, there are 4 key strands of the active places workload in terms of playing pitch strategy, open space, sports facilities, and active travel. The first 3 are really about key facilities and services that are available, and then the active travel is making sure that the linkages are there to ensure that people can be active in their everyday lives, whether that's walking, cycling, to from work, school, or whatever, but also that by combining those 4 key strands, there's a real opportunity for placemaking across Thurrock, which is really about focusing on bringing those key strands together to maximise the opportunities and the linkages to help address or increase physical activity, which then has a knock-on benefit in terms of physical and mental health and well-being. So as part of the engagement process in delivering the study, we looked at a range of consultation and stakeholder engagement. Looking at engagement within the council, there's obviously some cross-departmental engagement there in terms of with leisure, education, transport, public health and planning. But then looking at some of your external agencies, you know, people like Sport England, sports governing bodies, local access forums, you know, so that we can get a real handle on, you know, the agency input. And then it's really looking at some of that key stakeholder consultation with user surveys, public consultation, engaging with key user groups as part of that. So just to give you a highlight of some of the key research results and methods that we looked at. Obviously that consultation with key stakeholders and partners. We also ran an open space public consultation survey. We engaged directly with between 80 and 100% of sports pitch teams consulted as part of the process. Schools, primary and secondary, we've done a lot of face-to-face and workshop consultation with active clubs and key user groups across the area, looking at friends of groups. But not only was there consultation, we also then assessed the quality of sports pitches, open space site, indoor and built facilities, so that we could actually determine a clear supply and demand analysis on those key facilities and provision across Thurrock. Obviously, this work provides a clear evidence base, and that evidence base supports the local plan as well as the health and wellbeing strategy. But it's really important that the council has that clear evidence base moving into a local plan which takes you through to 2037. It looks at, which also provides that, I suppose, an evidence for identifying planning requirements from developers. We know that there's significant housing growth across Thurrock, so there's a real opportunity to make sure that community facilities are engaged as part of that and benefit as part of that. It supports funding applications, again, through the local football facilities plans and potential Sport England investment, but also provides actually an evidence base for statutory consultees to comment on planning applications. And as an example, Sport England would use this work to then inform their, you know, statutory planning processes as part of that. It also gives you a real opportunity to look at what needs to be protected and mitigated based on major infrastructure developments, likes of the Lower Thames Crossing. And that, aligned to the last point, aligned to cycling and walking, which just makes sure that, you know, you have a real opportunity to ensure that cycling and walking is key to the future network of facilities and the connectivity across Thurrock. And I suppose the challenge with the LTC is that it puts a new road network through the borough, which then is an important aspect of that east-west connections across Thurrock. So building up in terms of the open space, obviously the key purpose of the open space is to ensure that there's appropriate and accessible open space across Thurrock. Some of the key findings, there's over almost 1,400 hectares of open space across the borough. One of the key challenges is that there's 56% of sites score above the quality threshold, but flipping that means 44% are below the quality threshold. But I think the key challenge there is that 91% of those are high value to residents, and that comes out from the consultation survey. So in terms of, we developed 5 key policy recommendations which we suggested to manage and maintain the borough's open space, and consider how enhancement of low quality sites could be achieved, or the development of those sites where they are also low value. And I think this is it's got to be strike a real balance between quality and value to the community in those areas, and also protecting those high quality, high value sites. And actually looking at parts of the authority where there is low provision, that the council looks to protect and enhance those sites across those key areas, and be flexible in terms of using the typology, so that there is flexibility to change typology as and when that may be required, so that I suppose the real needs of communities are met. I think one of the key things is, within this context, that allotment and cemetery provision is, as you would suspect, demand-led based on that. Looking at active travel, again, the real purpose there is to have high quality, accessible and sustainable networks, which really contribute to the quality of the environment, enabling people to be, or the inactive to become active, and really looking at improving the walking and cycling networks to improve long-term health and well-being. Obviously some key findings there in terms of the amount of and the number of public footpaths, bridleways and cycleways. I think one of the key challenges across the area is the pollution levels. Again, aligning that with the LTC, aligning that with the need to try and get people as active as possible so that they can walk, cycle to work, and improving that connectivity is really important. And I think active travel isn't just about, getting people active. There is an economic growth aspect to that, in terms of the wider health standards, tackling congestion, that is really important across that. The approach to active travel is really to look at 2 key aspects. One is the physical improvements, but also addressing mental barriers, and that is really through the promotion, the education and incentivization of using walking, cycling networks. So we've identified the range of routes that need to be improved, but also there's a need to make sure that that's coupled with, which is especially relevant in the current pandemic situation, is where people are possibly more aware of walking and cycling routes than they previously were aware of. So there's a real opportunity to build on that, moving into a post-COVID era where that can be maximised and used for best effect to achieve that wider physical activity engagement and active travel opportunities. So those are the 2 key aspects on active travel. The sports facilities and playing pitches have, they have a joint overarching strategic purpose, and that's about high quality, accessible, sustainable facilities. Again, really allowing people to participate in sport and physical activity to improve their long-term health and well-being, but also enabling the inactive to become active. Obviously, there are key links to health and well-being strategy, but this isn't just about sport, it's also about physical activity. It's about actually physical mental health and well-being. And really there's an opportunity to link in with other service areas, and we've seen that across a range of local authorities where actually the reach of physical activity facilities to do good, if you want to, or to reach into the most hardest parts of the community, they've achieved better where there's been co-location with other key service areas. And I think that's obviously an aligning factor for this. So looking at playing pitches, key findings are that there's lots of overplay on playing pitches. There's deficiencies, most notably in artificial pitches, and the quality of changing areas need to be improved to that degree. Key recommendations are in and around the grounds maintenance and increasing that capacity, and that's especially on grass pitches, which the key focus here is not necessarily identifying new open space sites to create pitches. It's about increasing the carrying capacity of existing pitches to help meet the needs and the demands for sports pitch provision. Key changing room improvements. There is a need to work to develop new floodlit artificial pitches, which then contribute to not only the playing but the development opportunities for young people in terms of physical activity, whether that's football, rugby, hockey, whatever. There's a need to work with schools and educational establishments, especially on the quality of provision, but also the accessibility. And we've seen that as a real challenge during COVID, where schools are less likely to open their facilities up for community use, and really to work with NGBs to help deliver on some of those key playing pitch investment priorities. Regarding the indoor facility stock, I think there is a need for new swimming pool provision to replace the existing stock across Thurrock, and as population increases the demand for those facilities. Swimming is full at capacity during the peak periods. One of the challenges across Thurrock is that all your sports hall provision is on education sites, so there's a lack of access during daytime, but actually the quality of that sports hall stock is a challenge where even on those school sites 50% need to be improved, and there is a real opportunity to look at key specialist sports such as gymnastics, which are good in relation to the key fundamentals of early years movement and development, which provide that strong linkage, that they are popular participation sports, and there's a potential for a permanent facility to help deliver on that. In terms of key recommendations, I think we're identifying that Thurrock needs to consider how new sport and physical activity provision links to the new integrated medical centres. And I think we would say that you potentially need to look beyond that as well. There's a real opportunity for placemaking, whether that also includes library provision, whether it includes, daycare centre provision, whether it includes nursery provision. There's a real opportunity to look at that wider offer as a much more integrated development that that should or could be considered as where appropriate alongside those. We need to look at developing sport and physical activity facilities alongside new schools, and that's not only in terms of the design of those schools, but the accessibility of them, whether that be daytime, evening, but the ability to add on to that provision to address what may be required within some communities, and also the ability to look at that from not only an indoor and built facility provision, but also an open space and active recreation perspective. You know, there are a range of strategic sites where you might want to create both that indoor and outdoor play, event, whatever kind of space that ties into that, again, that placemaking opportunity. So we'd like to just take you through a couple of examples of where, and I suppose this is the balance between what is the evidence base for the local plan and where authorities have used this kind of work to attract both external funding from developers, but also where they've used that then as match funding for subsequent external grant funding bids. So using the first example, Chorley, we done the suite of documents similar for Chorley about 2013, but between that period, they've generated over £3.3 million investment from Section 106. Chorley was a key housing growth area for what was the Preston City deal. So again, using that evidence base, they've identified additional investment in predominantly open space and playing pitch provision. The other end of the spectrum is Derbyshire Dales, where since 2018 they've generated £500,000 through Section 106, but that is an authority which is in the Peak Park and has got obvious restrictions there, very limited housing growth, but they've seen the benefit of using these studies to be able to attract that investment from developers. This is an example of St Helens, where they've used almost £1 million of Section 106 funding, but they've used that as match funding to create and enhance an existing playing pitch site, which has really resulted in more than double the amount of Section 106 through investment from other grant sources, such as Football Foundation, Sport England, to help develop that. So I suppose there are a couple of examples of how this evidence base needs to be used to really maximise the benefits. Looking at opportunities, I think from our perspective, the fact that you have major infrastructure development and major housing growth, actually having a clear evidence base for that does enable you to look at how you can access planning gain to help deliver on some of these opportunities. There is a big drive through integrated medical centres that, again, there is an opportunity for that co-location. We are aware that some of the NGBs and stakeholders have a real drive to improve provision across Thurrock. We're aware that the FA and the Football Foundation has got a real drive to invest, and we need to use those opportunities to help deliver those. What that has the potential of doing is delivering real revenue savings or revenue efficiencies, whether that is improving the overall viability or generating surpluses to be reinvested elsewhere. So if we take some of the 3G pitch development options, there's an opportunity that any surplus income gets reinvested into the provision of high quality grass pitches on key sites that helps contribute to that maintenance of those. Similarly, with built facility provision, there's a real opportunity to deliver those efficiencies. And we've had some authorities where they have looked at commissioned services. So where leisure centres may be quieter during the day, they've actually delivered commission services through day services for adults to deliver on those, to help drive some of those efficiencies, not just within the service, but across the authority. And the key focus of that is to deliver on those key health and wellbeing outcomes, but from I suppose a planning and local authority perspective, there is that drive to really look at Thurrock and deliver a range of placemaking opportunities, look at service integration or co-locations where it's appropriate, and really to improve the quality of the environment for Thurrock residents and visitors. So one of the key things that, in terms of moving forward, Sport England has now developed what it's called its strategic outcome planning guidance, and that's not just looking at the strategic connectivity across whether it's with sport, leisure and health. It's actually looking at the clear connectivity within service planning, service linkages, that cross-departmental working. And you're probably at the stage of having delivered a lot of your insight as strand 2 of the SOPG work. Now it's almost moving on to the interventions, but I think there is, to some degree, the challenge on ensuring that you have those combined outcomes that are clearly identified and everyone clearly works to across the authority. So I think that's just to show you where you are on the network of Sport England thinking at this stage, and where you may need to get to move things forwards. I suppose finally, in terms of the wider delivery and leadership of the active place strategic focus, I think this isn't just one department's responsibility. It's not just a planning evidence base, so it's planning's responsibility. It's not just recreation and leisure's responsibility. There's a real opportunity to take this and to make sure it's part of everyone's responsibility, whether that be education, transport, public health, and it needs to be a real collaborative approach. And that's from a council cross-departmental perspective, but it also needs to look at externally to your stakeholders, whether that's housing developers, where you are increasing significant housing growth across the period of the local plan. Actually, infrastructure, through LTC has a clear responsibility to tie into that. Similarly with governing bodies, the voluntary sector, and key partners and employers across the area. But coupled with that, you've really got some of your local clubs, friends of groups, community forums, the general public to help deliver on that active places strategy and to really move forward on that as a real collaborative approach. So, and I think that, from our perspective, is the real challenge now, and the challenge now begins to deliver that moving forwards. So that's questions, and I'll stop sharing this. Thank you.
Thank you very much for your presentation. I think Councillor Fish, put your hand up first.
Okay, thank you. Hopefully you can hear me, because I couldn't hear you very well there, Chair, just now. My question really is, one of the key objectives is to provide accessible facilities So, in one sense of access, how are you making sure that facilities? Hello? Can you hear me okay?
Sorry, could you repeat the question?
Yeah, okay.
Get that
Yeah.
there.
Okay, let's try again. One of the key objectives of the strategy is to provide.
Lee, can I ask you to say something? I don't know if you've lost me or if we've lost Karen.
Okay, I'll try again.
Councillor Fish, we can hear you at the moment. Councillor Haldon has frozen a little bit, but David, we can still see you and the rest of the group, so that might be just interfering with the discussion at the moment.
Okay, I'll just power on then and ask the question. So one of the key objectives is to provide accessible facilities, and obviously one of the senses in which facilities need to be accessible is for disabled people. So how does the strategy envisage consultation with disabled people to make sure that those facilities are right?
I think within any new facility development, or refurbished facility development that may be considered, current design guidance stipulates that all facilities should be DDA compliant, and we would anticipate that if the council is looking to undertake any key work and that they would engage with key stakeholders, engage with key groups, whether those be
David, if I can,
disabled groups.
I think.
Sorry?
Question is about accessibility.
So I think I lost that there.
I understood you. I heard your answer anyway. So if you want to carry on.
Yeah, I think so. Accessibility will be built into any of that. I think within any developments, accessibility would be core to that, and I think key groups would be consulted, as whether that's through project development phases or whatever. So I think that would be standard moving forwards, if that answers your question.
Up to a point, I think it's important to identify the right groups, the groups that have people that can give the most valuable information. So I'd like to, further down the line, maybe follow that up and see exactly who is being consulted to get that information right.
Yep.
Okay, does anyone else have any comments? Not seeing any hands up. Lee, perhaps a question for you. In terms of where the council is going in terms of assets, fewer buildings, better services, where does this strategy fit in with that? Because I know a couple of comments about needing better swimming pool provision, and we know different sports groups across the borough are not always thrilled about some of their facilities. So how does this fit into the wider play setting agenda, Lee?
Thank you, Chair. Yeah, I think it should be seen as, so all of the evidence base and the studies supporting the local plan will all interact to a certain degree, and as will discussion around assets and the like. I think this is about ensuring that residents, both existing and future residents and future communities, have access to high quality facilities. I think it was interesting that David, one of the sort of results that David was referring to was the percentage about quality and of value. So it's understanding what communities see as being valuable open space and how we can address that quality aspect to it as well. So it's really looking at ensuring that there's sufficient quality that people do value in the community. And I think this is where the APS really provides an important baseline, a sort of baseline evidence to inform that, because then that can inform not only the local plan, but it can equally show what residents and what the existing communities see as being valuable in their own local ward or their patch, as it were, and that would then help inform decisions that are perhaps made on open space in the widest sense as in the council's own assets as well.
Okay, so do we particularly envisage this to be an ongoing process where perhaps we use the local plan to create the quality of facilities we're talking about, or are we thinking more in terms of going back into the existing stock of bowls clubs, sports pitches, rugby pitches, etc., and trying to bring them up to scratch? Because I'm trying to get a sense of, is this future provision we're looking at, in which case it's kind of a local plan place setting agenda, or is it bringing up the existing provision, which is really a capital expenditure agenda?
Thanks, Chair. And David or other colleagues on the call may want to comment as well. But for me, this is around a little bit of both. It's about looking at what the existing provision is within the borough, what the existing conditions are for our existing population, but looking at that as a starting point. And then when we look at what growth may come about through the local plan, is then ensuring that those facilities or those provisions are increased, improved, and then delivered to support that growth via the local plan.
Yeah, sorry, I would just confirm that it is very much about almost using or trying to understand how growth can assist and help contribute to part of the redevelopment of the existing, as well as improving some of the existing that's going to stay in place. So it is very much a local plan, almost working document, but I think the responsibility and the options for those really rests across departmental and with stakeholders.
Thank you. Christina, you've got your hand up.
Thank you, Chair. Wrong button. It's just around the kind of consultation and community engagement. So the responses to the active place strategy was quite low in the respondents on that. And I was just wondering if there's a commitment with the development of this going forward, that there will be a wider engagement of communities, including the disabled community, around that too.
Chair, I see that Jahur has his hand up, so I wonder whether Jahur is able to answer that at the same time, perhaps.
Yeah, please go ahead, Jahur.
Hi everyone. Yeah, I think obviously this document, the APS that was created, this is a start of the conversation. As we've mentioned, initially the consultation was with sports clubs and sports groups that have facilities. I think the plan is, once this goes forward, there will be a wider consultation with the general public and with other stakeholders. I think the opportunity of having an APS is not only for the local authority, it's also for sports clubs. There are several sports groups who want to upgrade and improve their facility. They're looking for funding from Sport England and from their governing body. And without APS, it's difficult for them to evidence why there's a need and why there should be investment in their facilities. So I think this is the start of the conversation. The plan was initially, once the APS is adopted, there will be a wider consultation, and it's an ongoing process that's reviewed every 6 months with stakeholders and partners. That's the long-term plan, because this is a strategy for the next 17 to 20 years. So there'll be an ongoing dialogue. Also, before any development of any major facility, each of the sites will go through a full feasibility consultation and planning process. So this current APS doesn't set out what should happen and where. It just gives a broad outline of the facilities that are required across the borough and across different activities and services. But it doesn't specifically set out what should go into any specific location. I think that would be part of a ongoing discussion, and that would be another opportunity where the public and the residents and colleagues would have an opportunity to get involved and ensure that the individual projects that come out of the APS are connected and have the right requirements and facility mix for each of the communities where they're based.
Okay, thank you for that, Jaher. Just picking up on what Councillor Fish was saying, what Christina was saying, looking at the 5 strategic recommendations and reflecting on consultation, 2 of the recommendations, arguably 3 out of 5, really are looking at schools. Now, I think that's a very good strategy. As a former Cabinet Member for Education, I know that the vast majority of places we create are through schools. So that's a sensible plan. But in terms of our older population, we've got a growing elderly population who we hope will remain fitter and active for longer, despite the fact that they're retired and officially OAPs. And we've got an ever-growing population of learning disabled, autistic adults who are supporting in the borough. So is there anything at all we can look at in terms of those 5 recommendations and either tweak one or create a 6th to really look at the often forgotten communities when we talk about place shaping, the more elderly, the learning disabled? Because I feel it's quite education heavy, which is brilliant, and I think it's going to address 90% of the issues that we need to. But I'm just wondering what can we do with that remaining 10%?
I think if I can come in there, I think we've one of the challenges that we identified was the fact that Thurrock does not have any activity space, sports hall space as an example, which is not on school sites. So within the work, we're looking to ensure that sports hall space can be delivered, at any new provision that's being developed. And that is, that's key, because that is one of your challenges, and that is one of the challenges for the older age group communities to be able to be active in a wider range of activities, indoor activities as an example. So this doesn't preclude or exclusively identify schools as the solution. It just says that you have an opportunity where you are developing schools, and that opportunity should be considered and maximised where possible.
Yeah, thank you. That's very helpful. And I'm most certainly not disagreeing. I'm just thinking that we've recently passed an autism strategy where we're talking about keeping that population in economic employment. And I very much felt that the missing part of that strategy was not just focusing on their physical medical needs and focusing on their economic employment needs, but thinking on the place, the whole live, work and play agenda for the borough. So I'm just hoping that before this comes to Cabinet, we can perhaps a point for Lee, that we can just have a thought about how we really address the less considered groups, the less physically able groups, perhaps. Does anyone have any other comments? I'm not seeing any hands. If anyone's struggling with their hand function, please just feel free to shout in. No. Okay. Well, everyone, thank you very much for that. colleagues presenting the active places strategy. If you want to stay for the rest of the extreme exciting meeting, you're more than welcome to.
Thank you. Bye.
All right, we'll move on to initial health assessments for looked after children. Sheila, are you presenting that? Or is Nintara?
Yeah, thank you, James. Nintara will be presenting this to the board.
Oh, sorry, I've just seen that there's another row. Yes, Nintara is on. Yeah, Nintara.
Good afternoon, everyone. I'm Nintara Khosla. I'm the strategic lead for Children Looked After, and I'm presenting an updating report for initial health assessments. So the purpose of bringing it here is to provide an interim update in relation to how children's social care and health colleagues are improving the timeliness of initial assessments. As I've noted in the report, the Ofsted in November 2019 highlighted the delay, and they acknowledged that there were plans in place to improve the communication between health and social care around initial health assessments, but they wanted to be assured that the pace of change was in place. So there is a full report coming to the Health and Wellbeing Board in January from health colleagues who've been working very hard with social care to ensure that we are providing initial health assessments and reviewing health assessments for all children who are entering into the looked after system. So in terms of why we have an initial health assessment, it's a statutory health assessment which is required for all children who become looked after, and we Children's Social Care are responsible for completing the referral and ensuring that all of the information is available so that that initial health assessment can take place. So the initial health assessment also informs the healthcare for those children who may all go on to be adopted as well. So it was really just to let the board know that there's been significant and continued improvement in the last year with new processes in place from August, and you can see in the data reporting that there's been improvement through September and October, and that has continued in November. So the key issues where we're having challenges historically were around administrative processes, which have been addressed. We now, through probably COVID, we're using the Teams meeting very effectively to share information, share in a weekly meeting. My thanks to Joanne Gurin for joining those meetings and really chasing where necessary to progress initial health assessments. The areas that are a challenge that Joanne and I have talked about are where those initial health assessments may be with other health authorities, and we've currently got about 3 that we're chasing across the country, from the southwest through to the southeast in London, that they have their own challenges. So each health authority can have their own backlog, and although Joanne is very proactive in contacting and escalating with other health authorities, it can be a challenge. What we are making sure is that Thurrock children are in the list and prioritised, and that local health authorities are not prioritising local children, so that Thurrock children are treated equally. So I think that it was really just to summarise, to note the progress that we're making, note the new systems that are in place, and highlight the excellent working relationships between health colleagues and with children's social care, which is working in a system that is quite complicated, and the paperwork is very tricky. So you're moving between local authority, health authority, other health authorities, and then passing the information back in the completed health assessment. So I think you can see that the progress that we're making. That's it, really.
Thank you very much for that. Natara, can I have Councillor Fish and then Jane Foster-Taylor?
Just a quick thing. You mentioned that the Teams meetings were part of the reason for the improvement. Is that because it's easier to bring people together and that kind of coordination is more difficult face to face? In which case, should we be continuing with the Teams meetings?
What's assisted with the Teams meeting is that we're able to share a shared spreadsheet, and so both organisations over the Teams meeting can look at that spreadsheet that we've both agreed is the document that we're going to use to track the children who need health assessments. And yes, we're absolutely going to continue with those Teams meetings. They have been invaluable and really constructive and beneficial, so that we're both looking at the same data at the same time, and it's got the same children that we're both worried about, and we're able to confirm the comments around why there might be a delay, and confirm what the escalation is. So we have a running commentary now, which is and a shared shared information. It's much easier.
Thank you, that's very helpful.
Thank you. Jane?
Thank you, Chair. Just to say, on the point about virtual, I mean, whatever possible for initial health assessments, we'd prefer them to be face-to-face, the better. We've used virtual for COVID. It certainly works for teenagers. They like it better. And it would be fine for a review health assessments, but for initial, we'd prefer them to be face-to-face. I think since we've had the SEND board, corporate parenting, brighter futures, I think we've had some real traction on IHAs, RHAs. We've got a new designate in post that's working with the local authority to make sure that that happens. There are opportunities where we could do things better. We're looking at whether the nurse role could be extended to pick up some of the initial health assessments, review health assessments. That's sitting nationally. It would be a change in legislation if we do that. And we're also looking at a set-wide Essex offer, perhaps for IHAs, and there will be an options appraisal that will come, and hopefully that can come to the Health and Wellbeing Board in January, and that might provide some opportunities because paediatrician capacity is limited, and so we may also be able to think of different ways of providing that service. So yes, no, we're making progress, which is great, and thank you for your report.
Thank you for that, Jane. I'm not seeing any other hands at the moment. Perhaps a question for Mark Tebbs. Myself and Christina certainly remember when Thurrock, several years ago now, was really struggling for initial health assessments for the learning disabled. That's much improved. As we've heard in this report, the initial health assessments for children, clear improvements are being made there as well. This is all great and this is all very welcome. Can you just reassure us that as we're now in a phase where we have a CCG alliance, opposed to just a coterminous CCG with us, that we're going to maintain the local capacity that we need to make sure that we have a permanent partner to, beat the drum to make sure these initial health assessments for children are done and we don't get lost in a wider shuffle? Because I think, as colleagues have mentioned, we're making improvements. We're not where we would like to be yet, quite. So we certainly don't want to slip backwards. Mark, if you'd like to come in.
Yeah, sure. Thank you, Chair. So there are as members will be aware, plans around looking at the kind of CCG mergers again, and that will probably happen kind of sooner rather than later. The kind of national direction of travel is still towards integrated care systems and CCGs that are kind of coterminous with that kind of bigger footprint. Within the kind of those ambitions around kind of coterminous CCGs, there is an absolutely unrelenting focus on place. So what we need to do is have structures that are able to deliver change at scale, but also not lose what we've the kind of the legacy of the place-based work that we've achieved so far. So it's both rather than either or. So we're working towards that. I think the work that this board, colleagues around the table have done in relation to the memorandum of understanding and that underpinning of what the role of localities are, the role of place, the role of the system is absolutely fundamental to ensuring that that's not lost. So, you know, it's you know, and obviously I've now been appointed as the Alliance Director, and I very much see that as my role, is to make sure that it doesn't become too centralised, that the kind of focus on places where the integration happens. It's where we need to understand our communities. It's where we can deliver services based on the assets of the community. It's absolutely, you know, it's absolutely where the integration happens. And I think the work we've done to establish the Alliance partnership, it holds us in really good stead. Our relationships are very strong, I think, and therefore, you know, I think it's up to us to make sure that the focus on place doesn't slip.
Thank you. Jane Foster-Taylor, you've got your hand up.
I did, Chair. Just to say, the other thing that Thurrock did is that we've obviously got Louise Warren, so we're the only CCG that's got, well, we share it with Southwest, but we steal most of her, the designated clinical officer for SEND, and that role we were discussing on SEND board was, you know, it's been pivotal with the relationship with education. It's been, and you know, we need to maintain wherever we can that role within Thurrock.
Right, thank you for that, Jane, and thank you very much for your response, Mark. Can I just ask Sheila, is there anything in particular that we've got currently in the system for children that we are currently lacking? We're making improvements in terms of the initial health assessments, but my understanding is most of those improvements are about busting some of the administrative barriers that we've had in the past. Is there anything in particular that we feel we might be cheeky enough to ask our NHS chums for, or do we just carry on in the current direction?
I think certainly in relation to health reviews, initial land reviews for looked after children, we are definitely going in the right direction and have built some strong partnerships there that's absolutely helping. I suppose going forward, it's just having a clarity with some of the changes that are happening, that we still have a focus in Thurrock and on place. And that's probably one of our biggest anxieties, if you like, in children's services, that it doesn't disrupt those partnerships that we are really forging well at the moment.
Thanks for that, Sheila. Ian Wake.
Thank you, Chair. Just on those 2 points, I think in terms of the focus on place, we need to refresh our place-based strategy for Thurrock, and there's work starting on that. There's a lot of really exciting transformation that's happened since Case for Change, and I think there's a need to bring that together. I know members of my team are working with members of Sheila's directorate on a place-based children's strategy at the moment. So I think that again will provide some further protection in terms of focus on Thurrock. And then finally, I mean, I really welcome the performance on this, but I think this is one of a much broader elements that we need to think about in terms of looked after children whom we know are a group that have some of the worst health inequalities and health outcomes compared to the general population. So I know my service is finalising a JSNA product on looked after children at the moment that we will bring back to this board and feed into those strategies. But I think that will give a much broader strategic focus to a whole range of programmes and initiatives and partnership working to try and reduce those health inequalities faced by this group.
Thanks for that, Ian. When do you think a draft of that looked after children JSNA might be in a position for colleagues to see?
It's in its second draft at the moment, I understand. So it's with Teresa Salami-Oru in my senior team. So I would think sooner rather than later, hopefully by Christmas, we can bring it back in.
Oh, what a gift that would be.
You did ask for it, Chair, so we always deliver.
Well, I'm going to try and avoid connections between you and Santa. Any other comments before we move on? I'm not seeing any hands, so thank you very much, Nintara, for your report. And I'm sure we endorse the recommendations unless anyone's got any objections. Jolly good. Item 7, worklessness and health JSNA. Andrea, are you sharing a PowerPoint with us?
I am, yes. I'll just open it. Bear with me. Right. Can you see that, hopefully?
Yep.
Yep, good stuff. Thank you. So good afternoon. Over the past few months, the Public Health, Place, Environment and Communities team have been working to produce a JSNA on the topic of worklessness and health. And I've just brought it here today to share some of the key findings from the project and to discuss the next steps to take it forward, really. So just to start, to acknowledge the people who produced this, it was produced by Public Health, but there was a wide range of stakeholders that have inputted into it. So very much thank you to those. Oh gosh, what's happened? Sorry. Right, okay. Sorry, skipping ahead. Okay, just to go through, to begin with the purpose of the project. So initially it was to understand the relationship between the worklessness and health and also the size of the issue in Thurrock. We decided that the target group would be working age people, so those aged 18 to 67. We would focus on employment support allowance claimants. And we also decided that we'd focus on those with musculoskeletal and or mental health conditions, because we know that these are the most prevalent conditions within the workless population, both locally and nationally. In addition, we know that musculoskeletal conditions and mental health conditions have a complex and often reciprocal relationship. So in addition to understanding the relationship and the scale of the issue, it was also a key aim of this piece of work to identify the barriers to employment in this group and what support is in place currently, or indeed what could be put in place to overcome them and get as many people as possible back to work where it's appropriate for them to do so. So why is this an important issue? What's the public health significance? So this is a diagram from the Office of National Statistics from last year, and it shows some of the national statistics. So in 2019 in the UK, we had 3.8% of the working age population currently unemployed. And at the time that was predicted to rise to 4.2% by 2024, although that may have changed over the last few months, that prediction. We know that the more deprived communities have higher levels of long-term conditions. And of those with long-term conditions, over half state that this is a barrier to work. Only 59% of people with long-term conditions are in employment compared to the general population, which is around 72%. So we know that worklessness is an important issue, both on an individual and a societal level. So on an individual level, it really is a key determinant of health. We know that returning to work after a period of ill health-related worklessness really helps that person's ongoing recovery and to their overall sense of well-being. By being in work, the chronic physical and mental ill health effects that can arise from these conditions, such as things like higher medication intake, can be significantly reduced or mitigated by that person being in work. On the other side, on a societal level, Models have estimated that the cost of sickness absence due to ill health could be around 100 billion a year nationally. Public Health England developed a return on investment tool around this and estimated that savings of just over £12,000 per person per year could be made if that person returned to work, and that would be spread across the NHS, local authorities and central government. Looking at the diagram here, if we just look at that stat on the right hand side at the bottom, by 2030 40% of the working age population will have a long-term condition. If we apply this to Thurrock and look at our sort of local population projections, it's estimated that the number of working age residents with a long-term condition by 2030 will be just under 50,000 people. So obviously, if nothing's done to reverse this trend or to mitigate the impact of it, then it will obviously result in greatly increased economic, health and social care costs locally. So just to touch briefly on the method that was undertaken by the team that produced this project. So the team obviously did some evidence searches of research papers and other literature, looking to answer the questions around barriers to work, strategies and projects for return to work, and the principles of a healthy workplace. What sort of workplaces can keep people at work in the first place and also then assist them back to work if they do go off. The team looked at data, so this isn't an exhaustive list, but they looked at GP survey data, quality and outcomes framework data, and also market statistics through NOMIS. They looked at, or they did some stakeholder and user engagement also, so they undertook some focus groups through the JCP and Recovery College, particularly working with the mental health and musculoskeletal groups. They tapped into staff networks, and as I've already mentioned, the GP survey also. These last two boxes, so they looked at national guidance. I'm not going to go through that, but just to highlight some of the national guidance that they did look at to triangulate with all the other information. And they also looked for examples of what is being done elsewhere that's been successful. And again, there's a list there of some case studies that are in the report, which you can look at in more detail if needed. Okay, so in terms of the key findings, so just to go over these quite briefly, so we know that some types of musculoskeletal conditions in Thurrock are on the rise. This includes things such as osteoporosis. This is in line with national trends. However, as I said earlier, this is still a concern. There's also significantly higher prevalence of common mental health conditions in Thurrock if we compare ourselves to the region east of England. We know that there's variation across the borough in the number of ESA claimants. So for areas of higher deprivation, there's larger claimant numbers as you would expect. So just to sort of, as an example, so the rate of ESA claims for musculoskeletal conditions ranges from 0.7 per thousand in East Tilbury to 7.9 per thousand in Tilbury St Chad's. And likewise for mental health conditions, the range is even larger. So it ranges from 3.1 per thousand in South Trafford to 18 per thousand in Bellis. And I think this is really important to understand so that we can make sure that interventions and support services are being targeted to those areas of greatest need. In terms of the numbers of people claiming ESA in Thurrock, so in 2018, so just bear in mind that was 2 years ago now, there was just over 3,700 people aged between 18 and 67 claiming ESA. If it could be considered to be experiencing worklessness, and that represented at the time 3.4% of our working age population. In terms of the two groups that we were looking at, there was 600 people claiming due to musculoskeletal conditions and just over 1,700 claiming for a mental health need. And if we looked at those that with the right support could potentially return to work, there was 80 out of the 600 for musculoskeletal condition and 350 out of the 1,700 with a mental health need who, as I said, with the right and appropriate and timely support could potentially return to work. Just to touch on the services, I'm going to come on to this in the next slide, but the local specialist offer for mental health conditions was reasonably comprehensive. However, the report found that there was limited local specialist offers for musculoskeletal conditions. But just to caveat that, since I've been around presenting this to various groups, I've been made aware that since this report was pulled together, there is some new or additional support services either in the process of coming online or which have come online in the last few months. So that that may fill the gap. We need to look at that again. Just to go back to some of the services, so you can see there is a number of support services provided through Thurrock Council listed there, but also we have lots of examples of good practice in helping people to be work ready through third sector, community and voluntary services, which are listed on the right there also. I think one of the key strengths that really came out of this project was the strengths within Thurrock was around the economic development and skills partnership, which we have. So this is a group of partners within Thurrock that assist in devising the local strategy and policy for Thurrock. It brings together partners from local employers, education, DWP, and community employment support services. And what they do is they plan strategically for the future employment of our residents. They have an action plan which maps the needs of the borough and supports the development of local employment skills and training opportunities, for example. So that was really identified as a key strength. In terms of barriers to employment, this diagram here shows the complex web of reasons that an individual may struggle to find or indeed remain in employment. The studies that out there have suggested that there was a significant lack of confidence amongst out-of-work benefit claimants, that more assistance was sometimes needed with acquiring new skills and confidence coaching, for example. Sometimes financial support was needed to support that transition into employment. And also practical concerns, for example, such as access to transport, that sort of thing, also featured highly. However, as you might expect, those with musculoskeletal conditions and mental health conditions faced particular difficulties over and above some of these things in returning to work. So, for example, those with musculoskeletal conditions sometimes had physical difficulties relating to their conditions, such as pain, for example. And people with mental health conditions reported other barriers, such as discriminatory attitudes of employers and stigma, low expectations of health professionals, and also ineffective models of supported employment. So you can see it really is a complex web of reasons why some people would struggle to return to work. Moving on to the role that workplaces can play, because obviously they have a role in assisting those people back to work, but also in preventing ill health in the first place. This Public Health England diagram shows many of the factors that a healthy workplace should encompass. So, as you might expect, it incorporates things such as flexible working, encouraging healthy behaviours in the workplace, fast access to occupational health services, physiotherapy, for example. So I'm not going to go through each of these, but just to flag that up, is that is what is considered to be a good standard to measure up against. And just to follow up on the role workplaces can play, this slide just shows some of the local examples of what some of our larger employers are doing. You can see obviously Thurrock Council is in there. Again, I'm not going to go through these, they are in the report itself, but just point out there are similarities between them. As you can see, things like employees assistance programme, but there are also differences between them. And I think there's potentially things that we could learn from other organisations and sort of pull together a suite of best practice, I guess. Okay, just moving on to the key gaps that the report found. So there appears to be no strategic approach to worklessness and health. And whilst there was a variety of local services for worklessness in general and for mental health particularly, access to this support was sometimes found to be unclear and disjointed. And some of the feedback from the focus groups, for example, was that these were not always person-centred or flexible in their approach. As I've mentioned, the report found the limited services or support for musculoskeletal conditions. However, that is something I think which perhaps needs to be refreshed in light of new information that's come to light. Interestingly, it came up and it's come up in the groups that have presented this at as well, that fit notes don't consistently detail what a person may safely be able to undertake on their return to work without exacerbating their health condition. I think this was a key issue that came up. I think this is both a national and a local issue. It's not just Thurrock. And I think there was a national review in 2016 which suggested that GPs felt that they hadn't had sufficient training to be able to detail with confidence what a person could do on their return to work. So I think that's an area to take forward as well. I understand that I think there has been moves to enable other health professionals, such as physios, for example, to do those fit notes, which hopefully will tackle part of that. But I think it's still something that we need to look into moving forward. Next, that there was no overarching workplace health accreditation scheme being used amongst Thurrock employers. So there was either no accreditation scheme in place, or employers are using different ones. And this just means that we have a limited ability to do quality assurance on those and compare and contrast, that sort of thing. And then the final point on this slide is that there was limited uptake of the disability confident accreditation scheme. So we know in Thurrock there's just over 7,600 businesses. However, only 46 of these were signed up to this accreditation scheme. I'm not sure why this is or how that compares to other areas, locally or nationally, but it does seem a very low number, which I think needs further investigation. Just to round it up, there are many detailed recommendations in the report. I think they can be pulled together under 3 overarching recommendations, and really just under this first one, the development of a workplace and health strategy, which I think is the really key recommendation that we need to take forward to make sure that we have a framework of actions which encompasses both prevention and also assisting a timely return to work. Secondly, which kind of comes under that first one, but I think it's worth pointing out in its own right, is the development of a clear pathway support, which allows claimants to be signposted to the most relevant services in a timely and appropriate process. And then thirdly, as I've just mentioned, the development of a healthy workplace accreditation scheme for Thurrock, which we can then use to ensure good practice in relation to health at work and promotion of good health. So just to sort of finish off, just to quickly go through the next steps. So obviously the report was pulled together over a period of the last sort of 12 months. And as a result, we haven't dealt with the impact that the COVID-19 pandemic has had, and perhaps will continue to have as we move forward, both on health and wellbeing and the number and type of people unemployed. So proposing that the first step is to produce an addendum to assess the impact and the potential impact moving forward of the pandemic, and from that decide whether or not some of the recommendations either need to be tweaked or altered, or indeed if we need some additional or new recommendations. Alongside this, we'd also like to deal with or assess the impact of the rollout of universal credit, which is also something which is dealt with within this report. From that, we then go on to do to develop the workplace and health strategy. So I'm going to stop there and invite any questions or comments. So thank you. I'll just take this off screen sharing so we can discuss.
Well, thank you very much for your presentation, Andrea. I've got Councillor Fish, then Ian Wake.
Thank you, Chair. You mentioned that one of the barriers to work is discriminatory attitudes amongst employers. What can we do to address that?
That's a very good question. I don't have the answer to that. I think that is something that we definitely want to bring out through the strategy, to bring out, exactly what that means for both employers and for employees, and what practically can be put in place. Look at what other areas are doing that are facing the same thing, that sort of thing. But I don't have an answer for you on that today, I'm afraid.
Okay, I'll follow it up in future meetings, and thank you.
Ian? Ian, I cannot hear you.
You're mute. Sorry, beg your pardon. I think part of the answer to that last question is a very good question, maybe about some level of accreditation of employers around healthy workplaces, and then support that could be put in place in terms of that. I mean, addressing discrimination in the workplace, the council doesn't have any direct control over employees, but I think there's a lot of good practice that could be spread between employers, and I think there's a range of things that can assist from policy frameworks to training and, as I say, spreading good practice. I really, really welcome this report. So thank you, Andrea, for bringing it here. I welcome it for a few reasons. Firstly, being in employment, and particularly being in good employment, is without doubt the most mentally and physically health protective thing that we can wish for our population. And yet it strikes me that we haven't really joined the dots as well as we possibly could on this issue and how it links to health. We know there's a bi-directional relationship, so we know that poor physical and mental health is likely to lead to unemployment, and equally, as I say, employment is incredibly less mentally and physically health protective. But I wonder whether there's opportunities to really go forward in our new transformation strategy and place-based working to join those dots between things like employment services and the DWP with services that treat people for mental ill health, and the new and tremendously exciting new mental health community transformation model that Janie Garter and Maria Payne presented at the last members oversight and engagement board on mental health. So I'm really keen that the new strategy explores those opportunities. I think my only other reflection is in terms of COVID, actually. So we know that the current restrictions on population movement and tiers are potentially very mentally damaging and potentially very economically damaging, and I remain incredibly concerned about the long-term impact of those on our population. And so I think anything that we can do to try and support people in work and get people back to work in that context is absolutely critical. And finally, just the financial aspect of that. We know that the economic damage that lockdown restrictions cause are having a devastating impact on our ability to fund local public services. We certainly can see that in terms of the council's current position. And so, again, anything we can do to prevent unemployment and anything we can do to get people back into employment, I think in the COVID context is hugely, hugely important. So I really welcome the report and look forward to the strategy.
Thank you very much, Ian. Mark Tebbs.
Thank you, Chair. Yeah, I also really welcome the report. It's a really important topic. It's health is just such an work is such an important determinant of health. So it's great for it to kind of be pulled together. I also really welcome the kind of focus on the workplace. So a lot of the investment in mental health has been around the kind of individual and their kind of well-being and helping them to kind of return to work. But obviously, having a culture, a local culture where kind of workers, employers are kind of receptive to and not discriminating against people with mental health problems is equally important. So I really welcome that focus and the ideas around kind of a charter, etc. I think would be very welcome. I guess probably I don't quite recognise the description of the MSK service. So I think that the MSK service has changed really significantly from when this report was written. So I don't know whether there is opportunity to kind of refresh it, but I don't think it reflects the local offer now. And I just wonder in future how we kind of link it up a little better and kind of involve sort of health colleagues a little bit more in the drafting, so that we kind of absolutely have JSNA products that reflect the kind of latest position, because I think the MSK offer has improved really significantly over recent times. And then I guess, and then I suppose there's also the kind of, I think the fit notes issue is really tricky. I think, I think GPs often just say they don't necessarily know what someone is capable to do, because they don't know the work situation that someone is going into. So I think sort of the kind of national issues around fit notes is that kind of resistance around being asked to kind of kind of look into what someone can do in a workplace that they're not necessarily familiar with in a relatively kind of short period of time. So I think that's a tricky one to kind of to overcome. But certainly like it if we could kind of reflect the kind of the latest position on MSK, because I don't think it's accurately represented in the JSNA product at the moment.
Thank you for your comments. I completely take that on board. As I say, it's been produced over the past 12 months, and do accept that some of the data information in there is out of date, and certainly there is an opportunity now to refresh it moving forwards and make sure that it is all up to date. So absolutely take that on board. I think with regards to fit notes, you're absolutely correct. It is a really difficult one. I think there is some examples of other places that particularly larger, I think it would only work with larger organisations really, where they have an in-house physio, for example, as part of their occupational health team, who they get to review GP fit notes and add to them, etc. So I think there is learning that we can take from elsewhere. As I say, that might only work for large organisations, but yeah, definitely take on board your points there too. Thank you.
Thank you very much for that. One thing I would say is that the council is currently out of consultation on the economic recovery plan, and that's going to be the core document that the entire organisation is urged to get behind. So if it's real, but what can we do to make sure that this JSNA very, very quickly distills and interfaces with that consultation to make sure that the economic development strategy has clear understandings in regards to how we need it to face up with health. I know Darren is doing a great job on behalf of the economically vulnerable group that I'm the chairman of, to make sure that our comments about the economically vulnerable get into that economic recovery document. So what can we do to make sure that this work adequately gets in there? Roger's hand has gone up.
Can I make my apologies for being late, Chair, but can I make a suggestion? The economic development strategy is obviously being led by the Place Director under Andy Millard. There is a small steering group that's overseeing the delivery and the production of that, which I'm on. So can I suggest that we take the document and the output of that to that, well, I will take it to that group, to the Place Board, and make sure that the recommendations from here feed into that consultation process.
Excellent, that'd be very helpful. Your hand's still up, Roger.
Sorry.
No, I can't turn my camera on thanks to weak signal.
Okay, and my hand is down now, Chair.
Any other comments?
I think Preeti from Mid and South Essex, the Trust, has got her hand up, Chair.
My apologies, Preeti.
No, that's fine. Thank you, Chair. Thank you, Roger. Just a couple of points to make. So I agree with the comment around fit notes. So large organizations where we have our own occupational health teams, the fit people with fit notes could be referred to them, and that's how we assess their fitness to work and kind of phased return to work. So just wanted to kind of emphasize Mark's and Andrea's comments there. The main thing I wanted to kind of bring in here was across MSc, we have been over the last year, and I know Ian and his team, we've spoken to them about this. We've been working on hospital as an anchor institution program. So we've been developing it with Basildon as a base over the last year, with the aim for it to be across MSc, across all our sites starting 2021. And we are, obviously the aim is to create social value, create and retain local wealth. So I think it fits in with the work that obviously you're looking at from an economic recovery perspective, but we're also keen to explore opportunities to understand how we can be a more inclusive employer. So we are exploring, actually, starting September 2021, we'll have young adults with learning disabilities who will work as interns in our different departments. So that's already in process. And I think at this point in time, we think the site will be Basildon to start with. So we are very keen to explore anything else. So anything that, Andrea, you think is coming out of this piece of work, especially around keeping people well in work or bringing return to work for people with long-term conditions. If there are opportunities for us to explore as part of the anchor institution work, we would be really glad to do that.
Yeah, thank you very much. That would be really helpful.
Thanks, Britta. That's a very helpful offer in terms of kind of a bit of extra access to the anchor institutions. Roger, I wonder, can we impress upon our place colleagues the importance of when they actually start to arrive at the final version of their document, that before they formally publish it for the formal process of overview and scrutiny and Health and Wellbeing Board and Cabinet, that perhaps it is informally shared, certainly to members of Health and Wellbeing Board first, just to make sure it adequately does reflect this work and the work of the economically vulnerable task force. Because you know what it's like when these strategies are published, if they require substantial rewrites, doing so in public is often not the best way to get the result that you want.
Yeah, I'll certainly follow that up with obviously Stephen Taylor is leading on that, and I'll certainly liaise with him directly. I'll follow that up.
Thank you. Does anyone have any final comments on this item? No? Okie doke. Well, unless I hear any objections, I'm assuming everyone is content with the recommendations. Okay, we will now move on. I think we're now for Kerry Armstrong to present. Going on to the item on workforce.
Yeah, that's right, Chair. Good afternoon, everyone. I have got a presentation, so what I'll do is I'll just do a very brief introduction to the item, if that's okay with everyone, and then I will bring up the presentation, hopefully bring up the presentation, depending on technology, and then just obviously if there are some questions afterwards, be happy to take those away or to respond to those. So I think really just a means of introduction, working with the AS Eastern Region Market Development and Commissioning Group, a small group across all local authorities of the region were commissioned by that group to have a look at developing a workforce strategy, looking just at the care market. I think recognising the link between the stability of the care market and kind of the link between developing the workforce, and also the fact that we wanted to start to develop a different type of care market for health and social care. We've already talked about place-based and innovation and developing different types of solutions and needing a workforce that was able to respond to that. So over a number of months, working again across all the local authorities across the region, we've developed a workforce strategy, which you've got today to have a look at, and also been working with the Mid and South Essex Care Partnership workforce development group as well, and because obviously both of those strategies are interdependent in terms of workforce and how we develop and use them across both the NHS and social care, and because a number of the themes are very, very similar, and we need to make sure our approach kind of reflects what each other's doing in order that we don't kind of actually end up stealing or borrowing each other's workforce, then both items have been brought to you today just to reflect that connection. What I'm going to do now is I'm going to attempt to upload the presentation and then briefly send you through that. That's great, it's not there. Sorry, bear with me 1 minute. Darren, I don't know whether you've
I don't want to
got
pressure
that
you,
there.
Kerry, but
Kerry,
everyone
we
else
can
has
do
managed
that
the
for you
PowerPoint.
now.
Oh, thank you.
So Claire's going to bring it up for you now, so your presentation
thank
will
you
come
very
up.
much.
No worries, Kerry.
It worked earlier. Right, okay. I know you're pressed for time, so I'll kind of just go through this quite quickly. We just need the presentation, Claire. This is the strategy at the moment. Well, I'll just if I just talk to it, because I don't want to kind of waste people's time. So basically, in terms of the care market for adult social care across England, there are 1.65 million jobs and 1.52 million people employed or working in adult social care. This is based on 1920. So it's a massive sector. And in terms of Thurrock, there are 4,500 jobs, and they're split by kind of over 3,000 in domiciliary care and over 1,000 in residential. So it's a massive part of Thurrock's economy, and it's a massive part of the regional economy as well. So the failure to actually develop our workforce and deal with some of the risks around workforce is an absolutely massive risk to our overall market stability, and our ability to actually deliver good quality of care and enable people to achieve the outcomes that matter most to them. In terms of just kind of a few more stats, massive turnover rate at the moment across kind of the adult social care sector. So we've got around 32.9%. This again based on 1920, 32.9% turnover rate in the independent sector, which is around 850 leavers. But interestingly, 74% of those people actually remain in the sector. So it's not the fact that people don't want to work in the care sector, but actually it's more likely around terms and conditions, and around being able to kind of get the best kind of quality of kind of work-life balance and kind of work for an organisation that kind of actually treats them in the way they wish to be treated. The other issue that's worth pointing out at the moment is the percentage of workers that are actually in the 55 and above years old bracket. So 25% of our employees in the adult social care sector for the marketplace are actually aged 55 and above. So really kind of important that we start having recruitment campaigns that and start changing the nature of care work that attracts people straight leaving from school, college and university, and that they see it as a job and a career that they actually want to go into. As opposed to what's predominantly seen as something that's quite transient, that's often kind of a stopgap, and is often kind of suitable to fit in with family life. And again, we encourage that and want to kind of continue to encourage that, but there's got to be a balance over people seeing kind of being in a care job as a real career choice. In terms of obviously that's social care, NHS, there are similar issues in terms of some vacancy hotspots and turnover, particularly around nursing and midwifery, and also around medical and dental. There are others as well. And again, it gives us a real opportunity across health and social care to think about how we address those issues by creating different types of roles. So looking at how we can create blended roles across health and social care, and how we can start to look across the system and in place about what each other does, and upskilling, etc. So we can actually kind of release more capacity across functions, other than kind of having a siloed approach. So there are issues that are similar to both kind of health and social care. In terms of the regional health and social care regional care strategy, in terms of workforce development, our vision was to have a profession which people are attracted to, able to progress and to wish to remain, but really importantly, a profession that enables the people it supports to achieve what's important to them. So around that, 6 key priorities around recruitment and retention, creating career pathways, skills and values, wellbeing, equity and diversity, sector promotion and parity of esteem. Some are obviously ambitions and need need some influence and lobbying of others to achieve, whereas kind of other elements of those priorities are well within our control. And in terms of how we move the strategy on, they're the things that we need to start considering in terms of what we start to do to move those priorities on, to develop that vision. And we've also identified a number of principles that will guide that work. And I'm not going to read all of them out, but they are very familiar and very similar to ones that actually encompass our health and social care transformation work. So making sure that what we do around workforce development has a focus on being people-centred, right time, right place, right solution, flexibility and adaptability, strengths and outcomes, and trust and empowerment. So all key principles to drive us forwards. In terms of the Mid and South Essex Care Partnership, so health and care integrated workforce strategy, again some very similar themes arising around employment brand, creation of flexible integrated teams and roles, system leadership and talent development, culture improvement, filling hard to fill gaps through role and career development, and also embracing digital and technological innovation. And again, a number of those themes fit across both health and social care, and adult social care working very closely with the Mid and South Essex Care Partnership on its workforce development, and are involved in shaping a number of projects linked to how they're implementing that strategy. So we are very much involved in that work and ensuring it kind of fits across the health and care sectors. Just moving on very briefly, obviously just want to say how important it is that we take a whole systems approach to developing workforce. So looking across NHS and associated partners, social care, but also embracing the strength within communities, which obviously we've started to do with development of micro enterprises, but also identifying the assets and strengths that exist within communities, and also volunteering roles and opportunities as well. The last thing I wanted to say is that we've obviously looked at both the principles and the priorities within both strategies and made sure that they do align. Obviously, even though the strategies are broader than Thurrock, how we deliver that will be down to local determination and down to local fit. But there are some things where it just makes sense to actually have either a regional approach, whether that be a lobbying role, sharing best practice, maybe developing things that are difficult or hard to achieve across all of us, or just being able to actually start to share how we move towards the vision that I've expressed. So I know time's short, I don't want to go on any more. So just want to really present both strategies to you and ask you to note and endorse both of those.
Well, thank you very much for the presentation, Kerry. Any comments, chums? Oh, lots of hands. Okay, let's go with right. If we go in this order, please. Christina Jackson, Jane Foster Taylor, Ian Wake, Roger Harris, but we'll start with Tanya, because it's her first time for this meeting to talk.
Thank you very much. I just want to say thanks, Kerry. It's absolutely brilliant. And I absolutely agree. There are so many opportunities to do some joint work in this. Oh, can't you hear me?
Yeah.
Yeah. Yeah, so just want to say how I think there's so many opportunities for the joint roles, but also just around the recruitment. Sorry, I think someone else is talking.
Can everyone make sure their microphone's off, because I'm struggling to hear Tanya slightly.
Yeah, I was just going to say how great it is, and I think we've got so many opportunities to work together and have joint roles. And I just wanted to give an example where we did some joint recruitment, and I think where we've been talking a lot today about Thurrock the Place, I think a lot of people do want to work at Thurrock the Place. And I know at one time Children's went round with a bus to tour people around and say why they should come and work in Thurrock. And I think health, social care, children's doesn't really matter. We could all do a joint recruitment. And when we did that, people were really, really responsive. We said, we don't care who you work for. It doesn't matter what organisation you work for. Just come and work in Thurrock. And I think this gives us an opportunity to really get that back on board again, because it was very successful the first time.
No, I think that's a good point. Well made. Christina?
Thank you, Chair. Thanks, Kerry. I think what struck me with the report is the kind of age bracket, that kind of over 50s age bracket. And I just wonder if we're linking in enough with the ATA apprenticeship scheme that allows people to move around in their apprenticeship and try different positions within that across organisations. And also the opportunity with the Kickstart scheme as well of attracting some of the young people at the moment. I just wonder if we're kind of missing a trick there. Thank you.
Did you want me to come back on these, Chair, at all, or just for noting?
Come back on them if you've got something that you think is a substantial reply.
I don't know about substantial. I was just saying, I'm going to say to Christine to thank you for kind of actually flagging those up. Then the next thing for us will be obviously making sure that we have our local implementation plan as well. So I think it's really important to actually consider some of the points that are being made as part of that.
Thank you. Councillor Fish?
Thanks, Chair. I think it's a brilliant idea, brilliant strategy, much needed. And I particularly welcome the idea of taking on board people's values as much as their skills in recruitment. But how do we actually test that people have the right values during the recruitment process?
There are tried and tested ways of doing that have been developing. For example, we're piloting 2 wellbeing teams at the moment, and all of the wellbeing workers were taken on and recruited against a value base. So the interview process is quite different. The application process is often quite different as well, because it's about demonstrating values, not just on kind of skills, etc., and attributes. So there has been quite a lot of work, a body of work that's been developed by people trying and testing these methods. So they are there, and they do work quite well to make sure you have people that are coming into kind of the care sector for the right reasons.
Okay, thank you for that. I'll do some more research and try and find the evidence there.
Thank you for that. Roger, then Ian.
I think the workforce is most probably going to be the biggest single challenge we face over the next 10 years, because we can have the most wonderful strategies, the most wonderful policies, and even money, hopefully. But I think the biggest thing that all directors talk about and worry about is whether we're going to be able to attract staff and the quality of staff. It's also so much more complicated in social care. I'm not saying it's easy in the NHS by any means, but there isn't any equivalent to Agenda for Change. There isn't the workforce structure that there is. We're talking about the majority of care being delivered through private, voluntary, independent agencies, all of whom have their own recruitment policies, all of them have their own terms and conditions. A lot of staff on the national minimum wage. We have tried to upskill recent years with social care certificates and the work that Skills for Care have been doing, but there's no doubt it's still very much a low-paid, less qualified sector than in the NHS. So I think in terms of how we prioritise this went to the regional ADAS group a couple of weeks ago and was extremely well received. I think we need, as an organisation, as a council, both as a provider but also as a commissioner, we need to up our game on workforce, because I think we need to do more to support our providers, both in training, both in terms of other opportunities, but also making it as a career that's worthwhile, for people to get into. I mean, I'm personally a failure on this one. Both myself and my partner have both worked in the health and care sector and all our life, but none of our 4 children have gone into the health and care sector. So there's something why it isn't seen as an attractive. I don't know if because they've seen how we've ended up. Maybe I don't know. Maybe that's put them off. But there is something that hasn't attracted young people into the care sector for a long time. And I do think what we most probably need to do is come back to this, Kerry, with a bit of an action plan for us within Thurrock about how we're going to take this forward. Because, as I say, if there's a real worry that we just won't be able to recruit the staff, or in terms of the quality of the staff as well. And there's such high turnover in some areas that it will impact on our ability to deliver any of our strategies. So I think we've got to make this a higher priority than it has been over the last few years.
Thanks, Roger. Ian.
Thank you, Chair. I was going to make a similar point to Roger in terms of I think this is perhaps the biggest challenge. It was more of an observation. I don't know whether we have an answer to this now, but this strategy is being produced at system level, at MSC level. I can understand why that is because the NHS operates largely across borders. But it strikes me that a lot of the solutions to some of the challenges Roger has just eloquently outlined actually lie in our own transformation strategy. So if you think our IMCs, one of the key initial drivers was to address the underdoctoring challenge that we have in Thurrock and trying to create an environment that would make it kind of most attractive to attract the best GPs and primary care clinicians. If you think of Case for Change in terms of the mixed skilled clinical workforce or the wellbeing teams, one of the brilliant things about a wellbeing team is I think it gives some status and career structure to what was traditionally a domiciliary care worker and allows skills development and upskilling into other kind of routine clinical roles and community roles. If you think of our micro enterprises, another brilliant example where we've leveraged support the community with providing people with employment, and more recently our mental health transformation and the community model and the challenges we face around things like psychology. So I guess my challenge to us all is how can we ensure that a strategy that is being developed at system level actually integrates and reflects and adds value to our transformation work at place. And kind of connected to that, I think that it feeds into the last conversation and what Pretty was saying about anchor institutions. But I think in terms of our economic development, I think that, and particularly in the current COVID context and higher unemployment, how can we ensure that those jobs are going to our residents? So how can we really grow our own from the community, such that the investment is made in our own residents and our own local economy rather than bringing people from outside?
And Jane, your hand's up.
Yeah, just to say, I sit on the People's Board with Kerry, and underneath all of the agenda items are subgroups. So they're chosen specialist subjects. So there is a primary care workforce looking at new roles. There is mental health looking at new roles. There are opportunities because there's money for investment in staff, finding the staff to do the jobs or identifying new roles that will support things like primary care, like some of the mental health roles, is probably the difficult thing. We are looking at the branding within Mid and South Essex. We are looking at what's our unique selling point. But there are, even though we have got Agenda for Change, which is great and it simplifies lots of things, we have tensions that, if I just say London waiting, step out of Thurrock, 5 minutes and you move out of Fringe, and that's quite attractive. The other thing is that even though Mid and South Essex, we're going to have a descriptor and a way of recruiting and retraining staff, we have pressures by other people. So people are getting golden hellos and handshakes, etc., etc. So there is tensions even outside on all our borders of Mid and South Essex. And I think the other thing just to say is that as a CCG, we I think there's only 2 out of the 5 CCGs that have done it. We have student placements. We place students within Thurrock, and our hope is that we'll do that whole grow your own, and we can keep them. And our local shared roles that we've alluded to, like the IMCs, but also where we've done. We're looking at adult safeguarding and our care home role that we've funded through the BCF. They've been really quite transformational in some of the work that we've been able to do for Thurrock. So I hope we have a bit more of that, and we could perhaps have rotational roles, and we can do more going forward. So it's exciting.
Thank you for that, Mark.
Yeah, it was just picking up on Ian's point, which I think was absolutely right. It's great having strategies, and it's often the way of kind of getting money into local systems, etc. But a lot of the solutions sit at place, and I think it's really important that we're measuring it at a place level, because what I'm concerned about is we could have aggregate growth across Mid and South Essex, but actually that could hide inequalities and variances at different places. So I think it's probably an action maybe we take back through the TICP structure, and just make sure that we're measuring the workforce and looking at it through that place lens.
Good point.
Thanks for that, Mark. The only thing I would throw in, Kerry, is that, as Roger said, in terms of bringing forward perhaps a plan, a route map, I'd be really interested to brainstorm what some of the other local authorities are doing, because there are certain things, great ideas that we know just won't work here. We know, as I think Jane pointed out, in terms of London waiting, we know comparatively we're going to always struggle to pay something comparable to the city. We know that we've tried other things. We tried a form of key worker housing, which flopped directly on its face and just didn't work. So I'd be really interested in pooling all of the different ideas from different local authorities and systematically working through them and looking at which ones we think might actually take root here.
Thank you. Yeah, I'll note that.
Christina? Can't hear you, Christina.
Sorry, Chair, it was a legacy hand.
Okay. Dr. Khalil?
Thank you, Chair. I was just going to say, when it comes to the workforce in terms of general practitioners, GPs, I mean, Thurrock has got the least number of GPs when you look at per 1,000 population. I'm sure there's been lots of work done by Ian and his colleagues on that. But the good thing about that is, I mean, I'm sure Ian remembers about the locality which we started from Tilbury, allied healthcare professionals. I mean, so the way we work in general practice has significantly changed. It's not just the GP that is delivering the services. It is being done by people like social prescribers, paramedics, clinical pharmacists. I mean, those are the areas probably we should focus on. And I think it's working really, really well. We may not be able to significantly increase the number of general practitioners or GPs or the doctors, but we can certainly increase the number of allied healthcare professionals who would probably deliver the same sort of work that a GP is doing, but in a different way. So I just want to bring that up. And I think it's working really well in our 4 PCN.
Very good point.
Thank you.
Pretty and
Thank you, Chair. I think there are a couple of things. So one is a couple of years back, Health Education England published a report where they kind of looked at different age groups and what their job expectations would be for the future. So the new, the children who are in school or in colleges or universities will be looking for portfolio careers. They're not going to be like us in the same job for 40 years. They'll be looking for different experiences, half arts, half work, that kind of thing. And we've done some initial work with Essex County Council on sharing our apprenticeship levy with them so that we see how that kind of combination works. We're also, as I said, open to look at some other joint opportunities, especially, primary care is very much aligned. That's one area we're exploring, but care would be another field because we have HCAs, we have other jobs which could very easily be health or care. So I'll link in with you, Kerry, to kind of explore that a bit more and either feed in or take some actionable items back to the organization. And just to say, Chair, I have to leave at 4, so I'll have to excuse myself. Thank you.
Okay, thank you for that. Jane.
Yeah, just to say, I'm probably going to be contentious now. So we do also need to do it as system and place, because whilst the paramedics have been phenomenally successful within primary care, East of England Ambulance have struggled with recruitment because it's quite an attractive place to work. So it's consequences, I suppose. So we need I think they lost 48 paramedics for primary care. That's a chunk of their workforce. So as a system, we're looking at it.
Thank you, Jane. Rahul?
Yeah, I was just trying to make the same point as Jane was going to make, is there are only finite number of any kind of professionals, be it GPs, nurses, or allied health professionals. So taking it from one part of the system would mean the other part of the system might just suffer. And maybe I think we need to look at more of a rotational positions, where there are rotations between different health or clinical settings, which would not only help restrict the big drain, but also help the professional development of those individuals, where it's a very different environment with working within the ambulance services to working within primary care. Same thing with the physician associates or the pharmacists. And it's a very different environment working in a secondary care settings to working into a primary care settings. So I think in terms of the workforce and for future, I think we just need to look at how do we maximize the opportunity of sharing of workforce and also rotational positions, where we could have workforce working across different clinical settings on a rotational basis.
Thank you for that. I think we've now exhausted all of our hands. Kerry, have you got everything you wanted out of that?
Yes, thank you very much. So it was just the opportunity to bring that here and obviously, hear your comments. And obviously the challenge for me now is working out how we then get that kind of balance between the Thurrock strategy and delivery and kind of that's done at the system, and what elements different people do and what's the right fit. So yes, thank you very much.
Brilliant. And you'll have that done by close of play tomorrow?
Absolutely, if not before.
Great. Wonderful. Right, I'm assuming no one has got a problem with the recommendations. So we will move on to the primary care commissioning item. I think, Rahul, were you presenting that?
Yes, so it really fits in really well with the discussion we've been having. So there is a paper within your pack from, and what I've done is I've just tried to prepare some slides. So if you wanted to refer to your papers, it's from page 233 to 236. But I was just going to upload a few slides, which almost captures the essence of the paper. I'm just going to do that. So bear with me for a second. I'm not sure if members can see it now.
We can see that, Rahul.
Thank you, Darren. The flip side of presenting with the presentation is you can't see anyone's hand if they've raised their hands. So Darren, if you can help me with if anybody's raised their hand. So I think the aim of the paper was almost like to engage with our stakeholders to seek their support. So at the moment in time, we all know that NHS England commissions primary care services across Thurrock CCG. And aim was to just try and articulate some of the advantages and some of the disadvantages of taking on full delegation duties. So the CCG has made an application to NHS England to allow us to be fully delegated for commissioning of primary care services in Thurrock from the 1st of April 2021. And in terms of that, I think it would mean that the day-to-day management of GP practices, the responsibility will fall on the CCGs instead of NHS. There will be still certain uh, functions that will be retained by NHS England, but CCG will be solely responsible for procuring green contracts, variations, mergers, closures, and how we spend some of the monies that have been reinvested for primary care within primary care at a local discretion. So CCG has always worked with NHS England right from its inception, and but it has always been in a very limited, in an advisory role, without any authority of making things or implementing things in primary care without the endorsements of NHS England. And also the financial purse stays with NHS England for any decision making. So it's always been in a very limited capacity, and allowing us to take on the full responsibility of commissioning of primary care would mean that the CCG will have a greater authority and a greater powers on making some of the decisions that we think are we are best placed to make those decisions, as we know the practices, we know the local landscape, we know the demographics, and we also know the provider landscape in terms of the gaps that exist within primary care. So there are certain things, as I said, will not be within the scope of delegation. So I think the performance management of individual GPs, including managing their medical performance list, appraisals, and revalidations, will continue to be the function that will be retained by NHS England. And also primary care services would mean we are only looking for the commissioning or the delegation for primary care services, i.e. the GP practices. Other primary care services like the dental, community pharmacy, optoms will continue to be commissioned by NHS England. But I think what we're trying to do is, once we have had a good grip on the commissioning function of GP services, I think the next step would be to then try and see if we can get delegated authority for the other primary care services, like the dental, or pharmacy, and optoms. What we've also done is, I've just tried to highlight on this slide some of the functions that will be now carried by the CCG if we become successful, and the functions that will be retained by NHS England from the 1st of April 2021. So those were the few services. And in terms of why, I mean, we always get asked is, why do you want to go for delegation now, and why not, 3 years ago or 4 years ago? And I think the criticism we always get is and Thurrock has got a good primary care team and a good working relationships with the local authority, and so you are best placed to be able to take on the commissioning functions. But I think what we've always found that if we had taken on the commissioning functions about 3 years ago or 4 years ago, I think we wouldn't have been able to achieve some of the transformation piece of work that we've done within primary care. So we still remember back in the days when we only had 2 practices that were CQC rated good, while the other practices were still being inspected or were put in special measures or were inadequate or required improvement. To now is we've got all practices barring 2 that are rated good. We've just discussed on some of the points around Tilbury, some of the work that we've done in Tilbury, some of the case for change work that has been implemented within Tilbury, and some of the newer roles that we've introduced in some of our localities. So I think those we would have struggled to do had we been taken on the commissioning function, because I think, or we think, is the CCG wouldn't have had the time and the resource to then do both the day-to-day contract management, but also to do the transformation piece of work. We think now, I think we are in a position where we can do some commissioning functions, given that we've now got some PCNs, we've now got the Alliance. So I think we should be able to, we are in a position where we can take on greater roles. And again, it brings some advantages like, as we already commissioning the wider services, having a commissioning role of primary care services will give the breadth of skill sets to be able to analyze where the gaps are and then cover those gaps within both primary and outside of primary care services. We have better relationships with the practices. The practices are very much on board with this. We've done our engagement event with our practices, and they have given the support for our intention to make an application for delegation. And again, we've done our engagement events with patient groups. We've done engagement events with our alliance stakeholders, as well as our PCNCDs, and we've received good support from all our stakeholders and partners. So the aim was to come in here and inform the committee that we intend to make an application, and we would like to get your views on how would you like us to, or what changes would you like us to bring about in primary care. So I will just share with you some timescales, and I'll also seek your apologies because things have moved since we prepared the paper. So these are the timescales, and some of the things have since moved. So we were meant to know about the outcome of our application by tomorrow, but I think we've been informed of our outcome informally or formally. I'm not sure, but I've seen some emails flying around the outcomes of our delegation. So which is where we've been informed that NHS England has approved our application for being delegated to commission primary care services from the 1st of April 2021. So what we'll be looking now is between now and 31st of March is to start mobilizing the workforce, doing a skills mapping to make sure that we are fully resourced to be able to undertake these functions. We've got the right governance, we've got the right committees where we can be taking the issues around primary care commissioning between now and 31st of March. So I'll end there, and I'll seek your thoughts around what changes would you like to see when CCG becomes responsible for the commissioning of primary care services.
Well, thank you very much, Rahul, for a very upbeat report. And I had scripted myself a question, which Rahul was rendered useless by walking us through why we didn't go down this route a few years ago, because this is something I've always been very, very keen on, and I think it's terribly exciting. We are where we are now. So do people have individual comments? Roger Harris?
I think this is very, very welcome, Chair. I think it allows us to reinforce our place-based agenda in terms of the wider primary care, I suppose, commissioning arrangements, whether it's out of hours, whether it's around the hubs, whether it's around the enhanced workforce. I think there's a real opportunity. We just have to obviously be careful we don't, I suppose, get too sidetracked to too many disputes or contractual nightmares between partners that sometimes does happen in GP world, I know. My question is more about the longer term, that if again, there's still an issue around CCG merger. Is this possibly then only going to be for 1 year, and then it goes back into a wider system-wide arrangement, or is this something that's more likely to be longer term and stay at a Thurrock level?
So I'll attempt to answer that question, Roger, but I'll look at my colleague with Mark as well, because he's got the wider lens around the whole system wide. So our merger deadlines or timelines is to be fully merged and to be into a single merged CCG from the 1st of April 2022. So I think what we are looking is to work with our CCG colleagues within the Health and Care Partnership to ascertain what functions would be retained at system level and what functions would be retained at place level. Now, given the importance of place, PCNs, and some of the conversations we've had, I think the system looks this very much sitting at place level. Otherwise you lose the focus and you lose some of the transformation piece of work that you're trying to do. So I do see that primary care sits almost very strongly at place level, but I think some of the bits around contracts, performance management, procurement, I think that might sit at system level, but the day-to-day commissioning, the day-to-day management of primary care and transformation piece of work, working with the PCN developments, the additional role reimbursements, all of that, I think, very much sits at place level, including the primary care enhanced services, the local enhanced services, the direct enhanced services. I think that all will sit at a place level, but I'm more than happy for Mark or Anil to share their thoughts as well.
Thank you. Mark, do you want to go first?
Yeah, I think all of these things are still, none of it's set in stone at the moment. I think, even the kind of delegation that so exciting and that Rahul's described so well, we're still in the process of engaging with our practices on constitutional changes, for example. So, this is very live information and and subject to sort of changing timescales. There's still discussions nationally about legislative changes around ICSs, etc. So it's still quite fluid, I would say. But we are setting up a Thurrock-based sort of shadow primary care commissioning committee, and then we expect then there to be a Thurrock primary care commissioning committee that takes over from that kind of shadow arrangement. So, and that it's not something you can do at scale. The primary care is so embedded in place. The primary task is around how we're integrating services around PCNs, and it's difficult to do that unless you have the relationships and the patch and the needs and the populations and the community assets. So I can't see it going anywhere other than place in the long term, but it's difficult to be absolutely definitive because it's all still slightly fluid. The timescales, the national context is all kind of changing around our ears still.
Thanks for that, Mark. Dr. Cleville?
Thank you, Chair. Thank you, Rahul and Mark. I mean, like Mark says, it is still very fluid in terms of primary care delegation. We are almost there. We could say almost there in the sense that NHS England has said okay, but the practices still needs to come back with the changes in constitution. So it is still fluid. Now, Roger's question was, what happens if we merge? The truth is, I myself don't know what's going to happen in the next 1.5 years, 2 years in terms of merger. If at the CCG merge, as a statutory organization, you can have only one primary care committee. That's it. But the function will stay at place level. That will be there, but you cannot have two primary care committee for a statutory organization. But the only thing what we're looking at is at place level, we will have that freedom and flexibility to decide how we want to deal with the practice and all those things. But then again, structure, how it is going to span out is not sure. The ICS coming in, I'm sure the chair everybody is very well aware that the ICS probably is coming in for sure, but the CCG merger is still in the process. Same with the primary care committee. If it comes on, it depends what happens to the CCG, I guess.
Thanks, Dr. Cleville. That's very helpful. I think that in terms of Rahul's initial comments about the split between the commissioning, which will replace, and the management of contracts, which may take place at a system level, my gut reaction would be to want everything to be at place, simply because of how much we try and ensure that contracts interact with different parts of the system. So the reality is, in terms of contract management, it's likely that primary care contracts will be interacting with other Thurrock infrastructure, whether it be the voluntary community or local area coordinators or Thurrock Public Health. So my gut reaction would be to try and nail down as much locally as possible. In terms of the ICS, I've spoken to Mike Thorne and Mac this week, and I'm very supportive of the ICS application. The question I've got, and because it's a degree of legalese, I don't know if either Dr. Clear or Rahul can answer it. In terms of not being able to have committee statutory organisation, if we do go through with a full merger, would it not be possible for, at the system level, if we can only have one commissioning committee, to discharge its functions through a series of subcommittees? And it will just so happen that our subcommittee would be chaired by our Alliance Director. Is that not an arrangement we could shoot for?
Do you want me to say it, Mark? Sorry, Chair. I think you're absolutely right. I mean,
that's fine.
we are trying to work out how I think our priority is place, and our priority is the freedom and the flexibility that we should have at place level to deliver the services. That's what we are looking for. How it's going to look, we don't know. Yes, subcommittees. There will be some kind of organization at place level to manage the primary care, even if the CCG merges into one, but there'll definitely be a subcommittee sort of form, or an organization sort of form at place level to look after the practices and the primary care commissioning, actually. But we don't, tell you the truth, we don't know exactly what's going to happen, and we are still working on place level. That is a honest opinion.
Okay, well, I think, Roger, I think we've got a meeting coming up with CCG colleagues, have we not? It might be an idea of post that meeting, we look to some sort of representation to STP/ICS colleagues, just to get our foot in the door quite quickly in terms of how we see this fitting into an alliance agenda.
Yes, I think Mark's suggestion, there were a number of primary care related matters that we wanted to pick up. So we're in the process of getting that meeting set up.
Brilliant. Well, we can aim to crystallise some thoughts coming out of that meeting, and I can go and share those with Mike and Mac. But Rahul, thank you for the report. I think generally this is a very exciting direction of travel. And I'm very, very supportive. Are there any other final comments? No? Okay. Right. We will move to an update from tab A&E. Mark?
Yeah, thank you, Chair. I've also got a few slides, which I'm going to go through very, very quickly. Cool. Can everyone see those? Cool.
Not as of yet.
No. Showing up on my.
There we go.
Yep.
Yeah,
I can see it.
Yeah, got them.
Okay, so so there's been some discussions in the background around just the absolute importance of getting the messaging right around the Think NHS 111 first work. So we've been so there's a national program which will start next week, following some kind of local early implementers that have happened this year. So for us locally, it's about the kind of implementation of that kind of national model, but it's happening really quite quickly, and colleagues will start seeing in the press, in the media next week, the kind of start of that national kind of media campaign. And what the project is trying to do, and I'm going to keep this kind of brief, but what the project's trying to do is to make sure that A&E departments are not full, and what they're trying to avoid is the risk of infection through COVID, of having kind of overcrowded A&E departments and people waiting in those departments for long periods of time. So that's the kind of primary kind of drive of the work. And to kind of achieve that aim, this kind of program of work is going to advertise that people should think NHS 111 first, and that they should call 111, and that 111 will then provide booked appointments in A&E, so people will have to wait less time in A&E to be seen, and that the waiting rooms will therefore be less full, and the kind of the infections or the risk of infections through kind of close contact in that environment will be reduced. So that's the primary driver between the work. So there's been a number of kind of must-dos that we've needed to put in place. I say we, I'm not actually sure whether Emily's still on the call, but I have asked Emily, I did ask Emily. Oh, brilliant, thank you. So all of the local work's been driven by Emily, who's kindly kind of come on the call. So if there's any questions, she'll be able to answer those, because she's the real kind of expert on the work. But there's been a number of elements or must-dos to the work. So it's been about how we increase the capacity of 111 to cope, how there are alternative pathways for people if they call 111 and actually you don't need to go to A&E, that people have the mechanism of booking slots in A&E, and that I think to reflect the fact that this has been mobilised really quickly, that there is a lot of monitoring and evaluation in place to make sure that the patient outcomes are good, the experience are good, it's good for staff, and that it does indeed achieve those kind of critical impacts, and that underneath that there is both a national communication campaign and also a local campaign. The slides kind of go through some of the detail around how the pathway will work, and some of the timelines for that comms strategy. But I'm just very, very conscious of time, and I know that I'm overrunning by 15 minutes for my next meeting. So what I'd suggest is that we can circulate these slides, and I'm happy to take any kind of maybe any questions outside of the meeting, if there's lots of detail that people want to go into. But I'll probably pause there if I may, Chair.
Thank you, Mark. I will use my prerogative to throw my two pennyworth in. I think it's perfectly legitimate to try and better triage the demand at A&E. Inappropriate referrals to A&E are a real problem for patients, because it means they don't get the care they need as quick as they need it. So I think this is the right track to be on. However, in terms of the onward referral through 111, what is vital is that we are very clear on why people are ending up at A&E, i.e. are there primary care venues or others that are over-referring people? And secondly, we need to be clear that when people are being referred away from A&E, that they are being sent to quality alternative venues, again, whether that be primary care. So what I think my one plea to you is, and you've seen the letter that I wrote to our STP Chief Executive, is what can we do to engage with Thurrock Public Health and with the scorecard, the balanced scorecard that we have for primary care, to make sure that we are correctly identifying why people are going to A&E inappropriately, and if they're being referred away, making sure we can track that referral to guarantee that people are being sent to an appropriate venue and they're getting a quality outcome. I think the vast majority of people will support the new system if they feel the system is indeed working, because I don't generally believe anyone relishes the idea of going to sit at A&E for 4 or 5 hours.
Yeah, I've kind of rushed through the presentation just because of time, but there are quality alternative pathways, and there is an absolute strong focus on outcomes and measurements. So both from a kind of patient perspective, but also kind of looking at the numbers. So the quality of the alternatives will be absolutely key to the success of the work. But it's not primarily about diverting people away. The kind of primary work is around that kind of waiting room management and the kind of minimising the risks of infection. And I think the comms will reflect that. But there's definitely Emily will confirm there's going to be a huge evaluation and information gathering aspect to it. I don't know whether you want to add anything there, Emily.
Yes, thanks, Mark. So part of the evaluation of this won't obviously be just following the patients that we've booked directly into ED, but we'll also be looking at to see whether patients that we did, or rather that the IUC service did suggest another service for, whether or not they did still turn up at A&E. So, for example, if they were directed to primary care and weren't able to direct book through the IUC into primary care, couldn't get an appointment with primary care themselves, did they then just walk into A&E anyway? So we will be following that through as well. I mean, the idea of this isn't to primarily stop people going to ED, it's to give people booked appointments at ED, but there will be some that go through that clinical triage within the integrated urgent care service who are deemed not to require the level of service that an ED offers, and therefore they will be offered an alternative disposition, whether that be self-care, primary care, dental services, urgent community response teams, etc. So we will be monitoring that very closely, the impact on those additional services, not just the ones that flow into the ED.
James, I think you've frozen.
I think you're on mute, Councillor Horden.
Darren, it looked as if James had just frozen at that point. I don't know. Oh.
We can give Councillor Horden maybe a minute to see if he can get back into it, Roger, if you're content with that.
Yeah.
Darren, are you okay to just...
Am I back?
Yeah, you're back. We can hear you.
Oh, bugger this.
We can
Roger,
definitely hear you.
Oh, great. Thank you. I heard the vast majority of that answer. Thank you, Emily. So would it be reasonable, Mark, to ask if we could come back to board perhaps in February with some clear information as to how this new arrangement is working? Because I am very keen that, yeah, we have built the infrastructure in Thurrock with the GP balance scorecard. We have been very clear on focusing on calling out bad examples when we do see them, and I do want to make sure we roll this into that.
Yeah, that sounds fine. Emily, I'm just wondering whether February feels slightly too soon, whether kind of once the data has come to you and you've kind of collated it and having a reasonable amount of data to kind of show some trends, but I'll defer to you whether you think February is achievable.
I mean, we would be able to bring a few weeks worth of data to February, but the way that obviously the detailed information runs behind, as it does with all activity data, it probably would be better if it was a little later. What I'm quite happy to do, we can do kind of an offline report maybe in early January, just saying this is how it went in the first month in terms of the kind of soft intelligence and the informal kind of daily sick rep information, but that won't be a real sort of data analysis of any sort at that point.
Yeah, I think that would be very useful. I mean, I'm less interested in just broad raw data and more interested in making sure that the new arrangement does adequately sync with the Thurrock CCG and Thurrock Public Health, because we already have a lot of the infrastructure in place. in terms of managing the relationship between primary care and the acute hospital, much of the relationship that Mark and Rahul have spent so long building. So I just want to make sure that we are using those muscles to benefit the Thurrock system, and this isn't just a where it's a national scheme. Thurrock is just kind of being pulled along without any local intelligence really driving outcomes. Rahul, you're muted. Are you trying to?
No.
So I think, Chair, this is also possibly going to the HOSC as well in January, and then back to here in February. So I think we will be having a very careful and strong oversight of it. And I think when we have our primary care meeting, it might be useful just to talk through the detail about how it's going to be monitored, although obviously we won't have any results at that stage.
Yeah, it sounds fine to me. Right, unless there are any other comments, thank you everyone for your attendance. Apologies for the overrunning, but I think we've had a very good and substantive conversation.
Thank you, everyone.
Thanks. Yeah, thanks everyone.
Thank you, Chen.
Thank you.
Thank you, everyone.